Check and confirm the patient identification and match the microscope slide with the corresponding full blood count report. It is important to note the age, sex, and history of the patient since the blood film cannot be interpreted without this information. Histograms and scatter plots given by automated hematology analyzer provides supportive findings which is preferable to have by the side while examining peripheral blood smear. Blood films should be examined systematically, starting with macroscopic observation of the stained film and then progressing from low power to high power microscopic examination, since it is useless to place a drop of immersion oil randomly on the field and then to examine it using the high power or 100x objective. First, the film should be examined macroscopically to assess whether the spreading technique was satisfactory, to judge its staining characteristics. Also, increased blue coloration is caused by hypergamma-globulinemia, which can be monoclonal or polyclonal. Occasionally, macroscopic abnormalities are caused by precipitation of cryoglobulin, cross RBC agglutination, platelet clumping, or presence of clumps of tumor cells. The film should then be examined microscopically using a microscope correctly set up to give optimal illumination. The use of a low power is important since it allows rapid screening of a large part of the film. First, decision is made whether or not it is suitable for further examination. Spreading, fixation, and staining must be satisfactory, and there should be no artifactual changes produced by excess EDTA or prolonged storage. A well-spread film should have an appreciable area where cells are in a monolayer, that is, where they are touching and not overlapping, and white cells are distributed regularly. Examination at low power facilitates detection of abnormal cells when they are present at a low frequency, appreciation of roulet and red cell and white cell agglutination, fibrin strands or platelet aggregates which are often found at the edge of the film, hemoparasites like microfilaria or cryoglobulin deposits. Having selected the subtail region of the film where RBCs are just overlapping, a high power should then be used which allows better appreciation of variation of RBC size, shape, and staining. A manual differential of WBCs if needed can be performed and presence of abnormal WBCs can be looked for, and distribution of platelets can be judged and presence of platelet clumps can be excluded. The oil immersion lens or 100x power should be used only for the final examination of unusual cells and for looking at fine details such as basophilic stippling or rods or hemoparasites like malaria. Sometimes it is possible for a definitive diagnosis to be made from a blood smear. More often, the smear is an important tool in the provision of a differential diagnosis and the indication of further necessary tests. The blood smear can have an important part in the speedy diagnosis of certain specific infections. Otherwise, its major roles are in the differential diagnosis of anemia and thrombocytopenia and in the identification and characterization of leukemia and lymphoma. First, we will see anemia. The consideration of the blood smear and the RBC indices is a logical first step in the investigation of any unexplained anemia. Modern automated instruments impart valuable information about the nature of anemia by providing MCV, which gives a measure of average size of RBC, MCH, giving a measure of average amount of hemoglobin, RDW, which correlates on blood smear with anisocytosis, etc. Coming to hemolytic anemia, in hemolytic anemia, RBC shape is of considerable diagnostic importance as some findings are sufficient for diagnosis, like in hereditary elliptocytosis, hereditary pyropoikilocytosis, etc. Moreover, the presence of nucleated red blood cells suggests that bone marrow is producing increased erythroids, which is one of the result of hemolysis. Presence of spherocytes is not diagnostically specific, since this may result from hereditary spherocytosis or autoimmune or alloimmune hemolytic anemia. Microspherocytes may be present in low numbers in patients with a spherocytic hemolytic anemia, but are also characteristic of burns and of microangiopathic hemolytic anemia. In the latter, it is also important to validate platelet count, since RBC fragmentation and platelets may be of similar size. Cystocytes, usually with nucleated red blood cells, and thrombocytopenia are a feature of microangiopathic hemolytic anemia. Blood smear is particularly important in diagnosis of acute hemolysis induced by oxidant damage, the characteristic features being the presence of bite cells, blister cells, and irregularly contracted red blood cells. The latter should be differentiated from spherocytes, which are regularly round in shape. They have quite different diagnostic significance. Other features may aid in the differential diagnosis of hemolytic anemia. For example, the presence of RBC agglutinates, usually indicating presence of cold agglutinin, and erythrophagocytosis, which is often a feature of paroxysmal cold hemoglobinuria. Coming to macrocytic anemias. For patients in whom there is deficiency of vitamin B12 or folic acid, smear shows not only macrocytes but also oval macrocytes and hypersegmented neutrophils. And when anemia is more severe, there may be marked poikilocytosis with teardrop poikilocytes and red cell fragments. Liver disease and excess ethanol consumption are common causes of macrocytosis, with the blood smear usually showing round rather than oval macrocytes and lacking hypersegmented neutrophils. Target cells and stomatocytes may also be present. In elderly patients, myelodysplastic syndrome is an important cause of macrocytosis. Other findings that point to the diagnosis include hypogranular or hypolobulated neutrophils, blast cells, giant or hypogranular platelets, Pappenheimer bodies, and presence of minor population of hypochromic microcytic cells leading to dimorphic smear. When macrocytosis is the result of hemolysis or recent blood loss, smear shows polychromasia, which results from an increased reticulocyte count. Coming to microcytic anemias. Blood smear is generally less important in differentiating microcytic anemias since RBC indices and serum ferritin levels, sometimes supplemented by markers of inflammation, interpreted with clinical features, permit the diagnosis on majority of cases. Features that can be seen in iron deficiency anemia and beta thalassemia trait include elliptocytes, teardrop cells, and target cells. While basophilic stippling is more commonly seen in beta thalassemia trait, pencil cells are more often seen in iron deficiency anemia. Pappenheimer bodies and red cell dimorphism is seen in sideroblastic anemias, and basophilic stippling is a feature of lead poisoning. Coming to hemoglobinopathies. Smear is useful in diagnosis of sickle cell disease, particularly if there is an urgent need for diagnosis and if results of HPLC are not instantly available. Presence of sickle cells, target cells, and nucleated red blood cells are commonly seen in sickle cell anemia. However, it is important to note that sickle cells might not be seen in sickle cell trait. Thrombocytopenia and thrombocytosis. Falsely low platelet counts may be the result of small clots, platelet clumping, platelet satellitism, abnormally large platelets, or fibrin strands. Falsely high platelet counts may be the result of other particles like RBC fragments, fragments of leukemic cells, or fungi being counted as platelets. Examination of film is also important in thrombocytopenia to look for associated abnormalities like May-Hagelin anomaly, having WBC inclusions, microangiopathic hemolytic anemia, like I discussed before, in leukemias and lymphomas, having atypical cells, and in thrombocytosis to look for evidence of myeloproliferative neoplasm like basophilia. Coming to leukemia, lymphomas, or bone marrow failure. Smears must always be examined for finding atypical cells or blasts when there is unexplained leukocytosis, lymphocytosis, or monocytosis, or when there is a flag in automated hematology analyzer for atypical cells. Low counts are indicative of aplastic anemia, acute leukemia, hairy cell leukemia, myelodysplastic syndrome, or infiltration of non-hematopoietic malignant cells into the marrow. For two conditions, Burkitt's lymphoma and acute promyelocytic leukemia, smear is of particular importance because it facilitates rapid diagnosis and specific treatment. Probable factitious results. Now, apart from what is already discussed, highly improbable results may be factitious, resulting from accidental freezing or heating of the blood, from hyperlipidemia, or from presence of cold agglutinins, a cryoglobulin, a bacteria, or fungi. Occasionally, blood smear leads to a fortuitous diagnosis that can be very important to the patient, like detection of features of unexplained hyposplenism may suggest a congenital absence of spleen, splenic atrophy, deposition of amyloid in the spleen, infiltration of neoplastic cells in the spleen, or even splenectomy of which patient is unaware. In each case, putting the patient at risk for complications of hyposplenism. Conversely, failure to observe expected hyposplenism on smear may indicate presence of functional residual splenic tissue from accessory spleens.